Hey everyone, Dr. Steve here. You know it as well as I do, but most students need a B or better in A&P. But did you know that students are doing that all over the US using my Anatomy and Physiology Digital Suite as a low-cost alternative to expensive textbooks? Digital Suite delivers the key concepts of A&P with short, assignable tutor videos and a bulleted narrative study guide that not only explain the concepts of A&P, they show them happening. Combined with state-of-the-art dissection and physiology lab simulations and a vast question bank for quizzes, homework assignments, and exams, Digital Suite meets students where they are and gives them the tools to master the content. It's the perfect supplement to an OER textbook or just on its own. If you're an A&P instructor, contact your McGraw-Hill representative today and ask about Anatomy and Physiology Digital Suite. If you're a student, tell your instructor about it. There's a link to Digital Suite in the show notes of this episode. Get your B or better in A&P with A&P Digital Suite.
Ellie's Eden, part of Azure Standard, was created for people who care about being thoughtful with what they buy, what they eat, and where it comes from. Growing even a small garden is a simple way to live that out. With healthy plant starts grown in Oregon from trusted non-GMO seeds, along with quality garden essentials, Ellie's Eden makes it easier to begin. Gardening helps you slow down, choose carefully, and stay connected to real food and the land. Learn more about Ellie's Eden at azuresstandard.com.
Hey everyone, welcome back to my podcast, Anatomy and Physiology Bit by Bit. This is your host, Dr. Steve Sullivan, coming to you from Bucks County, Pennsylvania, where I've been teaching A&P since 2002. We are continuing on with our coverage of diseases, injuries, and conditions that are pertinent to not only healthcare providers, but to any human, because we've been focusing on the top 10 causes of morbidity and mortality, not just in the US, but in the world. So if you or one of your loved ones has a human body, then this is relevant to you. As always, this podcast is for educational purposes only and in no way should be taken as medical advice. If you or someone you know has any of the signs or symptoms that I'll be discussing today, then by all means go to the emergency room because today's topic is one of the most dramatic, time-sensitive, and life-altering topics in healthcare: stroke, cerebrovascular disease, and aneurysm. I'm on my own again today, so I've done some research thanks to the U.S. Centers for Disease Control, the American Stroke Association, the National Institute of Neurological Disorders and Stroke, National Heart, Lung, and Blood Institute, National Institutes of Health, and the Mayo Clinic. This is an episode where anatomy and physiology are not abstract at all. They are immediate. They are practical. They are the difference between walking and paralysis, between speech and silence, between independence and disability, and in many cases, between life and death. Stroke remains one of the major causes of death and disability in the U.S. According to the CDC, more than 795,000 people in the United States have a stroke every year. That's every 40 seconds on average. The CDC also reports that someone in the U.S. dies of stroke almost every 3 minutes. So today, we're going to build this topic from the ground up. We'll begin with the anatomy of the brain and its blood supply. Then we'll talk about what cerebrovascular disease means, what actually happens during a stroke, how ischemic and hemorrhagic strokes differ, where aneurysms fit into the story, what causes these conditions, who's at risk, what signs and symptoms we look for, how they're diagnosed, what the long-term ramifications can be, and what treatment and prognosis look like. And along the way, I want to keep returning to a central idea. The nervous system is only as healthy as its blood supply. I want to begin with a story about a guy I know that I'm just going to call Frank. A few years ago, Frank was in his late 60s. He was retired, he was active, he was funny, and kind of stubborn in the way that people can be when they've lived independently for decades. He had high blood pressure, but he didn't always take his medication because, as he put it, he felt fine. He smoked when he was younger, but he had quit by then. He had borderline diabetes and had been told more than once that his cholesterol was too high. One morning, while eating breakfast with his wife, Frank reached for his coffee and missed the mug. His wife noticed that his right hand seemed clumsy. Then she asked him if he was okay, and he answered with words that sounded garbled, almost as if he knew what he wanted to say, but couldn't get the words out correctly. When he tried to smile, one side of his face didn't move the way the other side did. At first, he resisted the idea of calling emergency services. He said maybe he was just tired. Maybe he had slept on his arm funny. Maybe it would pass. But his wife remembered the word FAST. F-A-S-T. It's an acronym for the classic warning signs of stroke. It stands for face drooping, arm weakness, speech difficulty, time to call emergency services. The American Stroke Association has upgraded it, and now you can often hear BFAST, B-E-F-A-S-T, adding balance problems and eye or vision changes to these warning signs. Frank's wife did call emergency services, which in the United States is 911. That decision mattered because in stroke care, this is not just time. Time is brain. The more time passes, the more brain function you can lose. By the time Frank reached the emergency room, the stroke team was waiting. He had a CT scan to look for bleeding. He had vascular imaging to look for the arteries supplying the brain. He was evaluated by emergency medicine, neurology, radiology, nursing, and eventually rehabilitation specialists. His diagnosis was an ischemic stroke involving the region of the brain supplied by the left middle cerebral artery. That sentence may sound technical, but by the end of this episode, it should sound anatomical. Now, if you look back to previous episodes, you'll find that I don't have one on the blood supply to the brain. So we're going to cover it here. Because when we understand anatomy, the symptoms make sense. Let's talk about the brain's relationship with blood. The brain is only about 2% of your body weight, but it consumes roughly 20% of your body's oxygen and a large share of its glucose when you're not exercising. Neurons are metabolically demanding cells. Unlike skeletal muscle, they don't store large amounts of fuel. Unlike adipose tissue, they can't simply coast through a temporary drop in oxygen. Neurons rely on continuous delivery of oxygen and glucose through the blood. This is why when your blood sugar is low, the first symptoms you feel are lightheadedness, dizziness. Those are brain symptoms. The blood that comes into the brain reaches the brain through two major paired arterial systems: the internal carotid arteries and the vertebral arteries. The internal carotid arteries are branches of the common carotid arteries and ascend through the neck. They enter the skull through the carotid canals of the temporal bones. They supply much of the anterior circulation of the brain. This includes major territories of the frontal lobes, parietal lobes, lateral temporal lobes, basal nuclei, and internal capsule. From the internal carotid system arise several major arteries, including the anterior cerebral artery and the middle cerebral artery. The vertebral arteries branch off from the subclavian arteries, travel superiorly through the transverse foramina of the cervical vertebrae, enter the skull via the foramen magnum, and join one another to form the basilar artery. Remember that the cervical vertebrae have a hole in each transverse process called a transverse foramen. The vertebro-basilar system supplies much of the posterior circulation, including the brainstem, cerebellum, occipital lobes, and parts of the temporal lobes. From this system arise branches such as the posterior inferior cerebellar artery, anterior inferior cerebellar artery, superior cerebellar artery, and posterior cerebral artery. From the names of these arteries, you can pretty much guess what parts of the brain they supply. At the base of the brain, these vessels are connected through a ring of arteries called the cerebral arterial circle, also known as the circle of Willis. The cerebral arterial circle includes the anterior cerebral arteries, anterior communicating artery, internal carotid arteries, posterior communicating arteries, and posterior cerebral arteries. In theory, this circle provides collateral circulation. The communicating arteries are what makes the circle a circle. They connect the arteries on the left to the ones on the right. So if one vessel narrows or becomes blocked, blood might be rerouted through the communicating arteries and still make it to its destination. So that's the average structural anatomy of these vessels. But in practice, the cerebral arterial circle varies significantly from person to person. Some people have a robust collateral system. Others have incomplete or narrow communicating vessels. Others have incomplete or narrow communicating vessels. That anatomical variation can influence whether a blocked artery causes a devastating stroke or a much smaller injury. The major arteries, as is typical for the circulatory system, then branch into smaller arteries, then arterioles, then capillaries, venules, and veins. At the capillary level, the blood-brain barrier helps regulate which substances move from blood into nervous tissue. This barrier is formed primarily by endothelial cells connected by tight junctions and supported by a basement membrane, pericytes, and the end feet of astrocytes. Remember, astrocytes are star-shaped neuroglia of the central nervous system. The blood-brain barrier is protective, but it also means the brain's extracellular environment is tightly controlled. When circulation fails, that controlled environment deteriorates quickly. A stroke is an acute neurological injury caused by a problem with blood flow to part of the brain. Most strokes are ischemic, meaning blood flow is somehow blocked. Some are hemorrhagic, meaning a blood vessel ruptures and bleeding damages the brain. Okay, now let's connect the vascular anatomy to functional neuroanatomy by discussing the major arteries and the parts of the brain that they supply. The middle cerebral artery, or MCA, is one of the most commonly involved arteries in ischemic stroke. It supplies much of the lateral cerebral hemisphere. On the dominant side, which is usually the left hemisphere in most right-handed people and many left-handed people, like myself, the MCA territory includes regions involved in language, such as Broca's area in the inferior frontal lobe and Wernicke's area in the superior temporal lobe. We'll talk about those later. It also supplies motor and sensory regions representing the face and upper limb. So a left MCA stroke might produce right-sided facial weakness, right arm weakness, impaired sensation, and aphasia, which is a language disorder. The anterior cerebral artery, or ACA, supplies more medial parts of the frontal and parietal lobes, including motor and sensory areas for the lower limb. So an ACA stroke may produce more leg weakness than arm weakness, along with changes in behavior, motivation, or executive functioning. The posterior cerebral artery, or PCA, supplies the occipital lobe, which is the primary visual processing center. So a PCA stroke may produce visual field deficits, such as a loss of vision on one side of the visual field. The vertebrobasilar circulation supplies the brainstem and cerebellum. Strokes here can be especially dangerous because the brainstem contains nuclei and pathways involved in breathing, heart rate, consciousness, eye movements, swallowing, and the long motor and sensory tracts that connect the brain to the body. A posterior circulation stroke can cause dizziness, double vision, trouble swallowing, ataxia, which is a loss of motor coordination that can result in slurred speech, walking difficulties, and fine motor skill deficits, weakness, numbness, or even locked-in syndrome if the ventral pons or midbrain are affected. Locked-in syndrome is a rare neurological disorder characterized by total voluntary muscle paralysis, also known as quadriplegia. And you also see an inability to speak. Meanwhile, full consciousness, cognition, and vertical eye movement are preserved. It's usually severe and often fatal early on, but many survivors live for years with rehabilitation, communicating by blinking their eyes. The direct and indirect motor pathways go through the brainstem, which is why you see this. So before we even define stroke, we can already see why the symptoms vary so much. A stroke is not just a brain problem. It is a vascular event in a specific anatomical territory, and the symptoms reflect the function of the tissues that territory supplies. Okay, so now let's define the terms we need to use regarding stroke. We'll start with cerebrovascular disease, which is a broad term. It refers to diseases of the blood vessels that supply the brain. That includes narrowing of arteries from atherosclerosis, blockage of arteries by clots or emboli, rupture of blood vessels, aneurysms, vascular malformations, small vessel disease, and transient ischemic attacks. Speaking of transient ischemic attacks, often called TIA or mini-stroke, this is a temporary episode of neurological dysfunction caused by reduced blood flow without permanent infarction, which means death of tissue. The symptoms may resolve sometimes within minutes, but a TIA is not something to dismiss. The American Stroke Association describes TIA as a warning stroke and notes that the symptoms are the same as stroke symptoms, even though they may go away fairly quickly. An aneurysm is an abnormal dilation or ballooning of a blood vessel wall. In the brain, aneurysms often occur where arteries branch or bifurcate into other arteries, especially around the arterial circle of Willis. It is a weak or thin spot in an artery that bulges and fills with blood. It may press on nerves or brain tissue, or it could rupture and bleed into surrounding tissue. A cerebral aneurysm may remain silent for years, but if it ruptures, it can cause a hemorrhagic stroke. The most common type of brain aneurysm is called a saccular aneurysm, often referred to as a berry aneurysm. It appears as rounded, pouch-like, or berry-like outpouchings on cerebral arteries. They represent 80 to 90% of all cerebral aneurysms and are caused by weakness in the artery wall that allows it to bulge. If you've ever seen a bubble in a tire tube, that's what I think they look like. They often remain asymptomatic but are highly prone to rupture. There's a misunderstanding of the term aneurysm in lay language. Many people use it to refer to the hemorrhagic event itself, like Bill had an aneurysm. But it's not. It's the rupture of the aneurysm that causes the bleed and, in turn, the hemorrhagic stroke. People can have an aneurysm without the stroke. If they're lucky, it can get caught before it ruptures and be repaired. An aneurysm can also occur outside the brain. They're common in the thoracic and abdominal aorta as well. So we can think of today's topic as a spectrum of blood vessel problems in the brain. Some involve blocked arteries, while some involve weakened arterial walls that may rupture. All of them come back to anatomy and physiology. Let's talk about ischemic stroke. We're going to get a little technical here, but it's nothing you shouldn't be able to follow if you've listened to previous episodes on cell structure and function, nerve tissue, and diffusion and osmosis. An ischemic stroke occurs when a blood vessel supplying the brain becomes blocked, depriving downstream tissue of oxygen and glucose. Without oxygen, neurons can't maintain aerobic metabolism, so ATP production falls, which means sodium-potassium pumps begin to fail. Without sodium being pumped out, it accumulates in the cells. Water follows sodium, so cells swell. Calcium enters neurons and triggers destructive enzymatic pathways. The neurotransmitter glutamate accumulates in the synaptic cleft, overstimulating receptors and worsening calcium influx. This is called excitotoxicity. As injury progresses, the central region of severely reduced blood flow becomes the infarct core. Remember, the term infarct means tissue death. Cells in this region are often irreversibly damaged. Surrounding the core is the ischemic penumbra, tissue that is functionally impaired but potentially salvageable if blood flow can be restored quickly enough. Much of acute stroke treatment is aimed at saving the penumbra. This is why time matters so much. An ischemic stroke can be caused by several mechanisms. One major mechanism is thrombosis, where a clot forms locally in an artery. Another name for blood clot is thrombus, which is where thrombosis comes from. It often happens at the site of an atherosclerotic plaque. We talked about atherosclerosis in the coronary artery disease episode, which was episode 81. But it isn't limited to the arteries of the heart. Atherosclerosis is the buildup of lipid-rich plaque in the arterial wall, and it can happen in any artery. Over time, plaque narrows the lumen, the internal space of the vessel, and disrupts the normal endothelial surface. If a plaque ruptures or erodes, platelets and clotting factors may form a thrombus that blocks blood flow. You may remember from episode 40 that platelets are also called thrombocytes because they're responsible for coagulation of blood, which is what forms thromboses. Another mechanism is embolism, where something forms elsewhere and travels through the bloodstream until it lodges in a cerebral artery. Most commonly, that something is a blood clot. A common source is the heart. One of the most common types of arrhythmias, which is an abnormal rhythm of the heart's electrical activity, is atrial fibrillation, or AFib. In AFib, the atria don't contract effectively, allowing blood to pool in the atria. Pooling blood that gets stagnant is a recipe for clot formation, especially in the left atrial appendage. If a clot leaves the heart, travels through the aorta and carotid circulation, and lodges in a cerebral artery, it can cause a stroke. This is why AFib not only calls for medication that will get the atria to contract properly, like beta blockers, it also calls for anticoagulant medication as well, commonly known as blood thinners, to protect against stroke. A third mechanism is small vessel disease, sometimes called lacunar disease. Chronic hypertension and diabetes can damage small penetrating arteries that supply deep structures such as the basal nuclei, thalamus, internal capsule, and pons. These small vessel strokes can produce highly specific syndromes, such as pure motor weakness when the posterior limb of the internal capsule is affected. Quick review: the internal capsule is the white matter between the thalamus and the basal nuclei of the deep cerebrum. A fourth mechanism involves systemic hypoperfusion, where global blood flow to the brain falls, as can happen with severe low blood pressure, cardiac arrest, or shock. In these cases, important areas between major arterial territories may be injured.
Ellie's Eden, part of Azure Standard, was created for people who care about being thoughtful with what they buy, what they eat, and where it comes from. Growing even a small garden is a simple way to live that out. With healthy plant starts grown in Oregon from trusted non-GMO seeds, along with quality garden essentials, Ellie's Eden makes it easier to begin. Gardening helps you slow down, choose carefully, and stay connected to real food and the land. Learn more about Ellie's Eden at azuresstandard.com.
So now let's talk about hemorrhagic stroke. Like I said before, a hemorrhagic stroke happens when a blood vessel ruptures. Blood escapes into the brain tissue or the surrounding spaces. There are two major anatomical categories we need to understand: intracerebral hemorrhage and subarachnoid hemorrhage. An intracerebral hemorrhage means bleeding directly into the brain tissue, intra meaning inside, cerebrum. Chronic hypertension is a major cause because long-standing high pressure damages small penetrating arteries, making them prone to rupture. Common locations include the basal nuclei, thalamus, pons, and cerebellum. A subarachnoid hemorrhage means bleeding into the subarachnoid space, the space between the arachnoid mater and the pia mater, where cerebrospinal fluid circulates. If you're not sure what I mean by that, you can review episode 23 where I cover the meninges and cerebrospinal fluid. The meninges are the three protective layers surrounding the brain and spinal cord. From deep to superficial, they are the pia mater, arachnoid mater, and dura mater. A classic cause of hemorrhagic stroke is rupture of a saccular or berry aneurysm, which I described earlier. The classic symptom is a sudden, severe headache, often described as the worst headache of someone's life. The Mayo Clinic emphasizes that a sudden, extremely severe headache requires immediate medical attention because a ruptured aneurysm is a life-threatening emergency. The mechanism of injury in hemorrhagic stroke differs from ischemic stroke. Whereas ischemic stroke causes injury by depriving brain tissue of blood, hemorrhagic injury is caused by blood physically disrupting tissues, increasing intracranial pressure, irritating meninges, triggering inflammation, and compressing nearby structures. If pressure inside the skull rises too much, other arteries get compressed, decreasing perfusion to the tissues they supply, which can cause secondary ischemic injury. In severe cases, brain tissue may herniate, meaning it is forced from one compartment to another because of pressure gradients inside the skull. So in ischemic stroke, the main problem is not enough blood reaching tissue. In hemorrhagic stroke, the main problem is blood escaping to where it doesn't belong. But both can ultimately deprive neurons of oxygen, distort anatomy, and interrupt neural signaling. Okay, now let's focus on aneurysms. The wall of an artery normally has layers. I covered the anatomy of blood vessels in episode 42. The innermost layer is the tunica intima, lined with epithelium. The middle layer, the tunica media, contains smooth muscle and elastic tissue. The outer layer, the tunica externa, provides connective tissue support. In an aneurysm, structural weakness in the vessel wall allows it to bulge outward under arterial pressure. Some aneurysms are discovered incidentally when a person has a CT scan or an MRI for some other reason. Other cause symptoms because they compress nearby structures. For example, an aneurysm near the posterior communicating artery may compress cranial nerve 3, the oculomotor nerve, causing ptosis, double vision, and a dilated pupil. Ptosis is a drooping eyelid. But many unruptured aneurysms cause no symptoms at all. Some small aneurysms have a relatively low risk of rupture, and management decisions depend on symptoms, history, family history, size, shape, and location. When an aneurysm ruptures, arterial blood enters the subarachnoid space. This can produce sudden severe headache, neck stiffness, photophobia, which is light sensitivity, nausea, vomiting, loss of consciousness, seizures, or neurological deficits specific to the region affected. Blood's not supposed to be in the subarachnoid space. Cerebrospinal fluid is. So blood in the subarachnoid space can interfere with cerebrospinal fluid circulation, leading to hydrocephalus, which is an excessive fluid buildup in the brain compartment. In the days after rupture, the products of blood being broken down can irritate arteries and cause vasospasm, narrowing vessels and creating delayed cerebral ischemia. So a ruptured aneurysm isn't a single event, it's often a cascade. An initial bleed, increased intracranial pressure, risk of rebleeding, hydrocephalus, vasospasm, seizures, and long-term neurological injury. So who gets these things? So we should talk about risk factors. Unmodifiable risk factors for stroke and cerebrovascular disease include age, because stroke risk rises as people get older, biological sex. There are some differences in risk patterns across the lifespan, but in general, biological males are at greater risk than biological females. Family history and genetics, prior history of stroke or TIA, and some inherited or congenital vascular conditions. Race and ethnicity are also associated with differences in stroke risks and outcomes, but these differences are not purely biological. They are deeply influenced by social determinants of health, access to preventive care, hypertension control, diabetes burden, chronic stress, environmental exposures, and structural inequities. For aneurysms, unmodifiable risk factors include family history, certain connective tissue disorders, polycystic kidney disease, and anatomical or developmental weaknesses in the vessel wall. So those are the unmodifiable risk factors. There's not a whole lot you can do about those. But you can do something about modifiable risk factors. That is where prevention lives, and once again, since the mechanism of cerebral vascular disease atherosclerosis, just like coronary artery disease, most of these will sound familiar to you if you listen to episode 81. The most important modifiable risk factor for stroke overall is hypertension. High blood pressure damages the endothelium, accelerates atherosclerosis, stiffens arteries, and weakens small vessels. It increases the risk of ischemic stroke, intracerebral hemorrhage, and aneurysm rupture, all the major kinds of strokes. Smoking is another risk factor. It damages the vascular endothelium, promotes inflammation, increases blood clot formation, contributes to atherosclerosis, and is associated with aneurysm formation and rupture. Smoking is the worst. When we look at these top 10 causes of morbidity and mortality, smoking is a risk factor for most of them, if not all. And vaping is not the answer. Just breathe air, people. You don't need all the junk in these things. Next is type 2 diabetes mellitus. Diabetes damages both large and small blood vessels. You'll remember from episode 82 that type 1 is not modifiable, it's genetic, but type 2 can be. In many cases, it's reversible. Diabetes causes chronic hyperglycemia, which contributes to endothelial dysfunction, inflammation, oxidative stress, and atherosclerosis. Diabetes also increases the risk of small vessel disease. Another modifiable risk factor is elevated blood lipids, or hyperlipidemia, especially elevated LDL cholesterol, which contributes to atherosclerotic plaque formation. Plaques in the carotid arteries or intracranial arteries can narrow vessels or serve as sites for thrombus formation. I talked about AFib before. Atrial fibrillation is a major risk factor for embolic stroke. The irregular rhythm allows clot formation in the atria, and those clots can travel to the brain. Other modifiable or partially modifiable risk factors include physical inactivity, obesity, poor diet, heavy alcohol use, obstructive sleep apnea, illicit stimulant use such as cocaine or methamphetamine, and poor compliance with medications for blood pressure, cholesterol, diabetes, or anticoagulation. You got to take your meds if they're being prescribed to you. This is where physiology becomes public health. A stroke may happen suddenly, but the vascular disease that sets the stage often develops over years. Let's get back to my friend Frank. Frank's stroke appeared suddenly at the breakfast table, but the pathophysiology didn't begin that morning. It began years earlier with elevated blood pressure pushing against arterial walls. It continued with cholesterol deposition, endothelial injury, inflammatory changes, and vascular narrowing. It may have been accelerated by glucose dysregulation and past smoking. The morning of his symptoms was the clinical event, but the disease process had most likely been underway silently for years. So let's talk about signs and symptoms, since we know what Frank went through. The signs and symptoms of stroke depend on the location of injury, the size of the affected territory, and whether the event is ischemic or hemorrhagic. Like I said earlier, the public-facing warning tool is an acronym called BEFAST. B-E-F-A-S-T. Balance, eyes, face, arm, speech, time. Sudden loss of balance or coordination can suggest cerebellar or brainstem involvement. Sudden vision loss or double vision can suggest retinal, occipital, or brainstem involvement. Facial droop can occur when motor pathways to the face are impaired. Arm weakness often reflects involvement of the motor cortex, the internal capsule, brainstem, or descending corticospinal tracts. Speech difficulty can mean the nerves that innervate the muscles of the face and jaw are malfunctioning, which is called dysarthria. Or it can mean aphasia, which means the speech difficulty is coming from the parts of the brain that control speech. Or it could be both. And time means call emergency services immediately. In the US, that means dial 911. Now, if you're a healthcare provider or student soon to be one, we should go a little deeper and more specific. A patient with a dominant hemisphere stroke may have aphasia. Aphasia is not the same as confusion. Remember, aphasia is a general term for a language disorder, but there are multiple different kinds because language is more than just forming words. Language is speaking, listening, reading, writing, gesturing, facial expression, tone, and understanding. So let's talk a little bit about the parts of the brain that contribute to language and what they contribute. There are two really important regions for language. First is the posterior speech area, commonly known as the Wernicke area. It's where the parietal lobe meets the temporal lobe, just caudal to the lateral sulcus in the dominant hemisphere, which is usually the left hemisphere. The Wernicke area is responsible for recognizing spoken and written language, as well as taking the thoughts that you want to convey into speech, converting them to the sentences that follow the rules of grammar, and transmitting that as a speech plan to the other area of concern, the motor language area, commonly known as the Broca area. The Broca area is in the inferior frontal lobe of the same hemisphere, about halfway between the forehead and where the frontal lobe ends at the central sulcus. The Broca area generates a motor plan so the muscles of speech can make the sounds necessary to accurately produce the words that the Wernicke area came up with. The Broca area then transmits that motor plan to the primary motor cortex in the precentral gyrus of the frontal lobe. That's where the initiation of voluntary motor signals takes place, so the appropriate muscles can be stimulated in the appropriate way. Now, here's something interesting. There's also an emotional aspect to language. We put tone in our voice to convey different emotions with what we're saying. Sarcasm, humor, sadness, joy, etc. Remember, it's not always what you say, it's how you say it. while the emotional aspect of language is controlled by the part of the brain directly opposite the Wernicke and Broca areas. Essentially where those areas would be in the contralateral hemisphere, which is usually going to be the right. The area opposite the Broca area is responsible for putting emotion and tone into speech, while the area opposite the Wernicke area is responsible for recognizing emotion and tone in the speech that you're hearing. I mean, this to me is about the most interesting thing about the brain. And as you can imagine, when something goes wrong, like a stroke, the signs and symptoms are based on where that stroke happened. For example, in Broca's aphasia, the patient may understand language relatively well, but struggle to produce fluent speech. In Wernicke's aphasia, speech may be fluent, but lack meaning and comprehension. In global aphasia, both production and comprehension are severely affected. So that's a really interesting part about language. Different parts of the brain are responsible for different aspects of language. So depending on where that injury is, you can have all different variations of language affected. Okay, moving on to other types of symptoms that are not language-based. A patient with a non-dominant parietal stroke may have something called neglect. They may ignore the left side of a space or fail to recognize their own left arm or eat food from only one side of their plate, shave one side of their face. This is not an eye problem, it's an attention and spatial processing problem. A patient with an internal capsule stroke may have dense weakness of the contralateral face, arm, and leg because motor fibers are tightly packed in that region. A patient with a cerebellar stroke may have vertigo, vomiting, ataxia, difficulty walking, nystagmus, which is fluttering eye movements, or headache. These can be missed because they may resemble inner ear disease, but cerebellar strokes can swell and compress the brainstem, making them really dangerous. A patient with a brainstem stroke may have crossed findings, such as weakness of the face on one side and weakness of the body on the contralateral side, because cranial nerve nuclei and long tracts are arranged in specific anatomical patterns. Some cross the midline in the brainstem, others don't cross the midline until further down the spinal cord. Remember, crossing the midline for neurons is called a decussation. Hemorrhagic strokes may produce many of the same focal deficits, but they are more likely to include sudden severe headache, vomiting, decreased level of consciousness, very high blood pressure, or signs of increased intracranial pressure. For example, a ruptured aneurysm classically presents with a thunderclap headache, which means a sudden onset, maximal intensity, often described as the worst headache of life. There may be neck stiffness because the blood irritates the meninges, along with photophobia, nausea, vomiting, collapse, seizure, or coma. The key point is that stroke symptoms are usually sudden and focal. The nervous system is organized, so when a specific region loses blood supply, a specific function is lost. Now let's move on to diagnosis. Stroke is diagnosed in a system of care, not by one person in isolation. The first clinician may be a paramedic, an emergency medical technician, an emergency physician, a nurse, a physician assistant, nurse practitioner, could be a neurologist, a radiologist, a neurosurgeon, or a neurointerventional specialist. In the pre-hospital setting, emergency medical services assess symptoms, establish last known well time, check glucose, evaluate airway and circulation, and transport the patient to an appropriate hospital. Last known well time is crucial because many treatments depend on when symptoms began. In the emergency room, the immediate goals are to determine whether the patient is having a stroke, whether it is ischemic or hemorrhagic, whether they are eligible for reperfusion therapy, and whether they need neurosurgical or neurocritical care. The first major imaging test is often a non-contrast CT scan of the head. This is fast and widely available. Its most urgent purpose is to identify bleeding. If the CT shows hemorrhage, then giving a clot-busting medication would be dangerous. If the CT shows no hemorrhage and the history fits ischemic stroke, the team may consider thrombolytic therapy depending on timing and eligibility. Additional imaging may include CT angiography, which visualizes blood vessels and can help identify large vessel occlusions, aneurysms, stenosis, or dissections. CT perfusion may help estimate the infarct core and penumbra in selected patients. MRI, especially diffusion-weighted imaging, can detect ischemic injury very sensitively. MR angiography can evaluate arteries without conventional catheter angiography in many cases. For suspected subarachnoid hemorrhage, CT is often the first test. If suspicion remains high despite negative imaging, clinicians may perform lumbar puncture to look for blood clots in the cerebrospinal fluid, depending on the clinical situation and the timing. A lumbar puncture used to be called a spinal tap. The physician draws cerebrospinal fluid from the lumbar spine by inserting a needle through the dura mater of the meninges. Since the spinal cord ends at L1, giving way to the cauda equina, the risk here is pretty low. For aneurysms, diagnosis may involve CT angiography, MR angiography, or digital subtraction angiography, which means a catheter is inserted, and that study helps provide detailed images of cerebral vessels. The Mayo Clinic describes aneurysm treatment decisions as individualized, based on features such as aneurysm size, location, appearance, and the patient's health and history. And the clinical exam is also essential. The stroke team may use the NIH stroke scale, which is a standardized neurological exam that assesses level of consciousness, gaze, visual fields, facial movement, motor strength, limb ataxia, sensation, language, speech, neglect, and other findings. It helps quantify stroke severity and communicate changes over time. Lab tests may include blood glucose, complete blood count, electrolytes, kidney function, coagulation studies, cardiac enzymes, and in some cases, the tests related to anticoagulant use. An ECG is important because AFib may be the source of an embolic stroke. Later evaluation may include an echocardiogram, which is an ultrasound of the heart, carotid ultrasound, prolonged rhythm monitoring, lipid testing, hemoglobin A1C for diabetes, and other studies depending on the suspected cause of the stroke. This is where the diagnosis becomes detective work. The immediate question is, what type of stroke is this, and can we treat it now? The next question is, why did this happen, and how do we prevent the next one? Because having a previous stroke is a risk factor for having another stroke.
I drive my bus in a busy city. That's why road safety is so important to me. I know that I must slow down and be extra careful when I make a wide turn. Buses need more room than cars. Everyone can help keep our roads safe. Next time you're driving, remember to give buses plenty of time and space to finish turning before driving ahead. Let's all plan to share the road safely. Learn how at www.sharetheroadsafely.gov.
Okay, so how do we treat it? For ischemic stroke, treatment focuses on restoring blood flow when possible, protecting the brain, preventing complications, and reducing the risk of recurrence. One acute treatment is intravenous thrombolysis, often discussed historically as TPA or tissue plasminogen activator. Basically, what those big fancy words mean is we need to dissolve the clots. The National Heart, Lung, and Blood Institute describes TPA as a main treatment for ischemic stroke that breaks up clots, blocking blood flow, and must be given within a limited time window after symptom onset. Some patients are potentially eligible beyond 3 hours and up to about 4.5 hours, depending on other circumstances. Another major treatment is mechanical thrombectomy. That sounds like fun. This is an endovascular procedure in which a neurointerventional specialist threads a catheter through the arterial system, often starting in the femoral or radial artery, up into the blocked cerebral artery and removes the clot using a stent retriever, aspiration device, or both. This is especially important for large vessel occlusions such as occlusion of the internal carotid artery or proximal middle cerebral artery. Supportive care is also treatment, by the way. The team manages oxygenation, blood pressure, glucose, temperature, swallowing safety, hydration, and complications such as brain swelling. Patients may be admitted to a stroke unit, neuro ICU, or intensive care unit depending on severity. For hemorrhagic stroke, the treatment is different than it is for ischemic stroke. The priority is to stop the bleeding, reduce hematoma expansion, manage blood pressure, reverse anticoagulation if necessary, control intracranial pressure, and determine whether neurosurgical intervention is needed. In intracerebral hemorrhage, treatment may include blood pressure management, reversal agents for anticoagulants, platelet or coagulation support in selected settings, seizure treatment if seizures occur, and sometimes surgical evacuation depending on location and size. In aneurysmal subarachnoid hemorrhage, the ruptured aneurysm must often be secured to prevent rebleeding. This can be done using surgical clips, where a neurosurgeon places a clip across the aneurysm neck, or by endovascular coiling, where coils are placed inside the aneurysm to promote clotting and exclude it from circulation. Some aneurysms may be treated with stents or flow diverters. The Mayo Clinic describes ruptured aneurysm repair as requiring surgery or endovascular treatment, with endovascular treatment occurring from inside the artery. Patients with subarachnoid hemorrhage may also need management for hydrocephalus, vasospasm, seizures, electrolyte disturbances, and increased intracranial pressure. Then comes the rehabilitation. Stroke rehab may involve physical therapy, occupational therapy, speech-language pathology, neuropsychology, nursing, social work, nutrition, and physicians specializing in physical medicine and rehabilitation. Therapy begins as early as medically appropriate. As soon as it's safe for the patient to start rehab, they usually are going to start. Physical therapy focuses on strength, balance, gait, coordination, transfers, endurance, and mobility. Occupational therapy focuses on activities of daily living, such as dressing, bathing, feeding, writing, and using adaptive strategies. Speech-language pathology may address speech production, language comprehension, swallowing, and cognitive communication. And neuropsychology may address memory, attention, executive function, emotional changes, and adjustment. This is one of the most important points of the episode. Treatment does not end when the artery is opened or the bleeding stops. For many patients, that is when the long work really begins. Let's talk about Frank again. Frank received acute treatment quickly enough that some of the tissue at risk was saved. But he didn't walk out of the hospital unchanged. His speech was slow, his right hand was weak. He became frustrated because he knew what he wanted to say but couldn't always say it. A fork even felt awkward in his hand. Buttoning a shirt became a task. Signing his name was sometimes exhausting. His wife later said that the hardest part was not just the weakness, it was watching a man who had always been independent suddenly need help with even the smallest of things. This is one of the human realities of stroke. The neurological deficit is anatomical, but the consequence, that's personal. If the left frontal language areas are injured, the patient may lose fluent speech. But what that means in real life is that a grandfather may not easily be able to tell a bedtime story. If the internal capsule is injured, corticospinal fibers are interrupted. But what that really means is that a person can't hold a coffee mug, drive a car, or even maybe return to work. If the visual cortex is injured, the patient may lose part of their visual field. But what that means in real life is bumping into door frames, being unable to read comfortably, or even feeling safe crossing a street. The anatomy becomes identity. So that kind of leads us to the ramifications and complications, which we really did kind of touch on throughout the episode. But just to sum it up, the immediate ramifications include motor weakness, sensory loss, speech and language deficits, visual deficits, swallowing problems, altered consciousness, seizures, headache, dizziness, and impaired coordination. Long-term ramifications are extensive. They may include hemiparesis, spasticity, contractures, chronic pain, shoulder subluxation, falls, aphasia, dysarthria, dysphagia, which is difficulty swallowing, depression, anxiety, emotional stability, cognitive impairment, fatigue, urinary problems, sexual dysfunction, and ultimately a loss of independence. We do need to give special attention to dysphagia. If a patient can't swallow safely, what can happen is food or liquid can enter the trachea instead of going down the esophagus, and that's called aspiration. And that can lead to an infection called aspiration pneumonia. This is why stroke patients often undergo a swallow screen before eating or drinking. And the immobility creates additional risks. The loss of mobility could create a risk for deep vein thrombosis, which means more risk for stroke because you've got more blood clots forming. Those thromboses could free themselves and become a traveling embolus, which gets to the lungs, forming what's called a pulmonary embolism. You can have pressure injuries on the skin, like bed sores. Deconditioning, you lose a lot of your aerobic fitness and joint stiffness. There are also social ramifications. A stroke may affect employment, finances, driving, relationships, caregiving roles, and mental health. And the caregivers often have their own set of ramifications like stress, exhaustion, and grief. For aneurysm rupture and subarachnoid hemorrhage, complications may include rebleeding, vasospasm, delayed cerebral ischemia, hydrocephalus, seizures, cognitive changes, endocrine abnormalities, and chronic headaches. And the prognosis varies tremendously from person to person. A small TIA with rapid evaluation and aggressive risk factor management may leave no permanent deficit at all, but just provide a critical warning for the future. A small lacunar stroke may cause weakness but allow substantial recovery, whereas a large MCA stroke may cause lifelong disability. Brainstem strokes could be fatal or devastating. A ruptured aneurysm may be survivable with good recovery, or it may cause severe brain injury or death. The prognosis is going to depend on the type of stroke, the location, the size, the time to treatment, age, baseline health, collateral circulation, complications, and access to rehabilitation. And recovery also depends on neuroplasticity, the nervous system's ability to reorganize and adapt. Surviving neurons can strengthen existing connections, form new connections, and recruit alternative pathways. Rehab works because the nervous system is plastic, but plasticity requires repetition, intensity, feedback, and time. Lots of time. This is another powerful connection to physiology. Recovery is not magic. It is cellular and systems-level adaptation. When students first learn the nervous system, they often memorize structures like the cerebrum, the cerebellum, the brainstem, the basal nuclei, thalamus, hypothalamus, cranial nerves, spinal cord. Then they memorize blood vessels, internal carotid, vertebral, basilar, anterior cerebral, middle cerebral, posterior cerebral. But stroke forces us to integrate them. I often tell my students and listeners that the human body, the nervous system especially, is mostly a collaborative effort. If the middle cerebral artery supplies the lateral motor cortex and the lateral motor cortex controls the contralateral face and upper limb, then a right MCA stroke can produce left facial droop and left arm weakness. If the posterior cerebral artery supplies the occipital lobe and the occipital lobe processes visual information, then a PCA stroke can produce contralateral homonymous hemianopia, which is a visual field loss on the same side, left or right, of both eyes, resulting from brain injury behind the optic chiasm. Symptoms often include missing half the visual field, and you could be bumping into things and have difficulty reading. So what you need to do is to look at the region of the brain that has been affected, know what those regions do, and how they communicate with other regions of the brain, and then you're going to understand the potential signs and symptoms when there is an injury in that area. I think it's important to remember that stroke is not just neurology. It's cardiovascular physiology, it's hematology, it's cell biology, it's pathology, it's pharmacology, and it's rehabilitation science. Let's go back to Frank one more time. Months after his stroke, Frank was not exactly the same person he had been before, but he was also not defined only by what he lost. He worked with a speech-language pathologist, he practiced naming objects, forming sentences, and reading aloud. He worked with occupational therapy and regained hand function. He learned to use adaptive strategies. He took his blood pressure medication. He stopped treating feeling fine as proof that nothing was wrong. At a family gathering, he raised a glass with his left hand because his right was still weak. He paused before speaking because the words came slower than they used to. Then he said, "I'm still here." That sentence is the heart of stroke recovery. The brain may be injured, but the person remains. Rehabilitation is not only about restoring function, it is about restoring participation in life. It's about restoring dignity. So let's sum it all up before we close the episode out. Cerebrovascular disease refers to disorders of the blood vessels supplying the brain. Stroke is an acute neurological injury caused by interrupted blood flow or bleeding. Ischemic stroke is usually caused by thrombosis, embolism, small vessel disease, or hypoperfusion. Hemorrhagic stroke is caused by blood vessel rupture, either into brain tissue or into spaces around the brain. Aneurysms are weakened outpouchings of blood vessel walls that may remain silent or rupture, producing subarachnoid hemorrhage. The anatomy matters because symptoms reflect vascular territories. The physiology matters because neurons require continuous oxygen and glucose. When blood flow stops, ATP falls, ion gradients fail, cells swell, excitotoxicity develops, and tissue dies. When bleeding occurs, blood damages tissues, raises pressure, irritates meninges, and can cause secondary ischemia.
I drive my bus in a busy city. That's why road safety is so important to me. I know that I must slow down and be extra careful when I make a wide turn. Buses need more room than cars. Everyone can help keep our roads safe. Next time you're driving, remember to give buses plenty of time and space to finish turning before driving ahead. Let's all plan to share the road safely. Learn how at www.sharetheroadsafely.gov.
For students of anatomy and physiology, stroke is one of the most important clinical applications you can study. It teaches vascular anatomy, brain localization, cellular metabolism, membrane physiology, cardiovascular risk, coagulation, imaging, pharmacology, and rehabilitation. But more than that, it teaches us that the structures we study belong to people. People with families, people with voices, people with stories, and people with lives. The brain is not just an organ of thought. It is the organ through which we move, speak, remember, love, plan, recognize faces, tell jokes, and understand who we are. And all that depends, moment by moment, on blood flow. Okay, that's it for this episode of Anatomy and Physiology Bit by Bit. Thank you so much for listening. Whether or not you're a student, keep studying the body bit by bit. And remember, when it comes to stroke, recognizing the signs and acting quickly can save brain tissue, function, and a life. I hope this podcast is helping you get your B or better in A&P. Good luck, be well, and I'll talk to you next time. Anatomy and Physiology Bit by Bit is a production of Minus 55 Media and is hosted by the Believe Network. Please take the time to rate my show and leave a review. You can also check out the content I post on Instagram and YouTube as @StudentHelp4AP. That's the number 4 AP. Special thanks to my family, Bucks County Community College, and McGraw-Hill Education, where your instructor can find Anatomy and Physiology Digital Suite, my low-cost tutor video-based digital learning solution for anatomy and physiology currently being used at several colleges and universities. If your instructor isn't using Digital Suite, let them know about it. The link is in the show notes.
I drive my bus in a busy city. That's why road safety is so important to me. I know that I must slow down and be extra careful when I make a wide turn. Buses need more room than cars. Everyone can help keep our roads safe. Next time you're driving, remember to give buses plenty of time and space to finish turning before driving ahead. Let's all plan to share the road safely. Learn how at www.sharetheroadsafely.gov.
If you like the show, please take a moment to rate, review, and subscribe. It really does help the show to grow. Thank you for listening.